Um, but yeah, welcome to the fall meeting. And this is our annual, everybody getting together across the Nephrology Collaborative. We're going to go through some presentations today. We're going to have some interaction, and then we're going to have an excellent educational presentation by Rajiv. So I'm just going to go ahead and get started. This is our agenda overview today. We're going to talk about the UACR performance metric, the first time we've had a performance metric in this collaborative. Then we're going to do, I'm going to present some of the data from the UACR survey. We'll have a breakout room discussion, 2 breakout rooms where we'll split up and talk about how we're working on these things as individual practices. And then we'll spend some time to report back out from that and hopefully learn from each other, maybe what common challenges we're facing, what our best practices might be, little tricks that we've learned to hopefully help each other. I'm going to provide some data on the patients in the collaborative, both overall and compared to primary care practices, and also across the different practices in our collaborative. And our team will give a little bit of an update on the dashboard and review that. And then, as I alluded to, we'll end the evening with an educational presentation on the CKM, which seems to be all the rage these days. And this is a topic that pretty much was the #1 topic by everybody in terms of topics to hear about at this meeting. So, and Rajiv has been a leader in this area on the forefront, so it's a perfect topic, and we'll have him present that at the end. As usual, please jump in anytime with any questions as we go along. So first topic again is introducing the UACR performance measure. I just want to say, to date, in the 3 years we've been doing this so far, and for many of you have been in from the beginning, the focus has really been largely on participation metrics, and a lot of the metrics for the VBR, the value-based reimbursement, continue to be, more participation-based metrics. But we finally feel ready to introduce a performance measure. And I think a large part of that was hard work by the team to make sure we had good enough data and to make sure that we were properly detailing this. And we chose urine albumin to creatinine ratio for a lot of different reasons. I think it's something that we're all pretty familiar with, of course, and it's something that we believe strongly is an important measure. And of course, it clinically, and of course, it's a HEDIS measure, so it's already something really arguably that we're supposed to be doing, and that there's already some reimbursement tied to. So some of the details, the baseline, the measurement year will be from July of 2025 to August of 2026. And this kind of 14-month window was chosen on purpose because not all of us see every patient exactly within 1 year. So we wanted to make sure that there was a window. The reward year will be the subsequent year. And then this will be done at the practice level. The target for this performance measure is a 5% absolute improvement based on the baseline rate. So again, this is an absolute performance improvement. So if you are at 54.5%, you got to get up to 59.5%. However, if you get to 90%, even if you're at 88%, you meet that goal. And then if you are already greater than 90%, we'll just ask to maintain that rate. The data that we're going to be looking at, the eligible population is all Blue Cross patients attributed to a MCT2D participating primary care physician. The age range is 18 to 85, and they have to meet the criteria for inclusion in the data registry and have appropriate data. And so we'll go over some of the dates in a second. The eligible physicians are any physicians attributed to a nephrology practice deemed eligible for VBR by Blue Cross Blue Shield of Michigan. So again, just to be clear in terms of what the performance measure is, the data, the numerator is the percent or the number of patients within that age group with type 2 diabetes who have a urine albumin to creatinine ratio recorded during the measurement year. The denominator is all the patients at the practice meeting the eligibility criteria. And just a technical note in terms of patients who are 85 years or older, once they turn 86, they will fall out of the numerator and denominator. So this is the timeline, the baseline period, again, a 14-month window, and then the measurement period, a 14-month window to hopefully capture as many patients as possible with the UACR testing. And this is what the timeline looks like for reporting out the data back to the practices. Should have already received the baseline report. And then we will do progress reports throughout the testing period. November 2025 will be the first progress report with the initial couple of months of data. You'll have a chance to review that and provide feedback. The next report will be in March of 2026, representing 5 months of data, and then August 2026 with 11 months of data, and then finally the final progress report in January of 2027. And as you can see, the data lags a little bit because these are claims-based data, so that's why the time frame is just slightly behind the actual measurement time, just to allow time to process the data and put together the reports. And this is how we're doing right now, basically at baseline. You should have all received an email with which practice you are in the collaborative. So this is de-identified, so we're coded MCIC 1 through 14. And you can see that there's a pretty significant range in terms of the urine albumin to creatinine ratio measure. And again, just to remind you, the metric is to improve by an absolute 5% for each of these. And we've only included the total percentages here. Obviously, the denominator matters in terms of how many patients that is in order to improve by. And you'll be able to look that up as well and see it within your own practice. And overall, I was a little surprised to see this, that the primary care practices are doing slightly better than us on this, but I think it actually kind of makes sense because they obviously have a larger, different denominator, and some of our patients may be more advanced. We may not be checking the UACR as much on them, but it's still going to be relevant for this practice. But honestly, overall, pretty comparable rates. And many of you have asked, how can, or we've asked, how can we help to improve rates of UACR testing? And this has been a really good conversation with the primary care practices as well. So one of the things that we're excited to announce is a new tool that was largely developed with the help of the MCIC team, and Julie Wright, who couldn't be here tonight, really helped to put this together. So this is a patient-facing handout about urine albumin to creatinine ratio testing to help educate patients on why this is important. We'll see in a little bit how one of the barriers is patients not leaving urine samples or forgetting or not being able to do that. And so hopefully some education around that will remind people that the urine testing is really important. And we will share these slides as usual after the presentation, and there's a hyperlink here that you can go to that will bring you to this handout that you can print out for your offices. And a quick segue from there, I thought it was just really interesting to potentially share the resource utilization of the resources from MCT2D. And this is just, like you can see in the background, a world map showing all the places that from which the MCT2D resource website has been accessed. So all across the US, but really all across the world. And over 140,000 users, 10,000 different cities across the world. And of course, really scattered throughout we've only shown the Lower Peninsula here, but really scattered throughout Michigan, utilizing the resources. I think it's easy to forget sometimes we're all really busy. We grab whatever's available to us, but we just want to remind people that the MCT2D website does have a ton of great resources that are freely available, really to anybody, but and certainly within the collaborative. This is a graph of the most popular resources, some that are nephrology related and some that are probably more geared towards primary care. But the number one overall that I thought was interesting and probably not that surprising was the 7-day sample meal plan for very low carb meals. And this is, something that's very pragmatic a lot of times when counseling our patients. And this might be something that's really helpful. Maybe we will be using this more as well, especially when we talk later about the CKM syndrome and the metabolic component of that. But you can see from a nephrology perspective, one of the highest things was with over 15,000 views was supporting patients during the incretin mimetic shortages, which hopefully have improved significantly. So and then there's a variety of other things here, meal planning, but also medication use, including the clinical decision aid. I think most of us are pretty familiar right now and feel pretty comfortable with the meds, but it has changed a lot. And just in the last year, the increased prominence of use of the incretin mimetics or GLP-1s, GIPs. And so if you haven't looked, that we did update this clinical decision aid, and it's already gotten a lot of views, but this was just updated this past month. So it's another thing worth checking out at the mct2d.org website. I just also want to say, I know having talked to some of you at the regional meetings, again, people brought up like, oh, it would be great if we had some of these handouts or different things like that. And so if you are thinking about that, take a few minutes to try to go to the website, and you can look under the resources tab, and you can search for some of these things and just see what's helpful. And if there's something you think would be really helpful that you can't find there or you don't see there, please let us know, because as we've mentioned before, we have an entire design team that is dedicated to helping put together educational materials like the ones you see here, or educational materials like this. So if you guys can think it up, we can help work on it and hopefully come up with a good design team effort to put together handouts or other educational materials that would be helpful for your practice and your patients. Okay, so I'm going to talk a little bit now about the survey that was sent. We appreciate everybody filling that out and returning it. We thought we'd just go over some of the results, and that could be a good segue into the discussions in the breakout rooms. So first of all, talking about the workflow for UACR screening in patients with type 2 diabetes. Most practices do this during the office visit, about 80%, and about 20% responded that they have no specific workflow around this. In terms of how the testing is tracked, it's really only a minority of practices, 3 of the practices, that have a system of tracking which patients are due or overdue for the screening, including manual tracking or using registries. In comparison, it's really 80% for primary care, 80% of practices are tracking UACR screening. And these are some of the different ways that they do it, through alerts or manual tracking, pretty equivalent. And some of the other systems include use of dashboards. And in terms of who manages the screening and the prompts in our offices, or who should be responsible, most of us felt like it was our responsibility as nephrologists versus a shared responsibility. And in terms of the availability of screening prompts in EHR systems, most of us apparently don't have that built in right now. And conversely, when we look at the PCP practices, most of them felt like it was either a PCP, and then a good chunk felt it was a shared responsibility with other subspecialists, including nephrologists. And again, I was interested to see this. And this is the data from the PCPs, where they seem to have more built-in screening for these kinds of things, probably because it is a HEDIS measure, and more available for them in the primary care setting. In terms of the barriers to testing, things came up that there was no urine testing available in the office, no reminders, which we just talked about through the presumably meaning the EHR, not being sure which patients needed the test, and then getting the incorrect test is something that came up a lot, or not ordering the right test. So we have seen that, some variability in terms of what labs report, and so that's one of the issues. But nobody had any concerns about the uncertainty around the testing guidelines. Just in comparison to the PCP offices, there were some other things in terms of no order reminders, not completing the right tests. So slightly different in a small minority of uncertain testing guidelines. In terms of patient level barriers, from our practices, the lack of follow-up from an external lab was the leading issue, the reliance on the external lab and not getting the results, or not getting the correct results. Once again, not being able to leave a sample in the office, transportation issues for patients to get to testing, understanding why the test is necessary, which was one of the prompts that the feedback we got that led to that UACR patient education monograph. And for PCPs, similar, not being able to leave the sample in the office, that seems to be a big issue, and obviously makes sense in terms of the convenience for the patients. So these are just some additional quotes that we got from you guys from the practices. So these first we asked, what can we do to work on this? So educating the physician to order it at least annually, provide more education on the importance of this, and hopefully the handout helps with this. How can we increase the testing in terms of workflow? One example from our practice was that the staff was reviewing each of the records ahead of time and then making a note or a flag in case it wasn't done, in order for it to be done, or at least ordered during the visit. The theme of team collaboration, talking about it at the monthly meetings to educate on the importance. And more frequent testing and follow-up. So basically just paying more attention to this and ordering the test more frequently. And then one of the themes was having electronic reminders for alerts to do this, to order the testing in patients that do not have it done yet. And more theme about education in terms of how MCTTD can support us in improving this. So more education all around, and that's something that we have really tried to pay attention to at the regional meetings. As you guys have attended, we have had specific talks on the importance of UACR and gotten good feedback from that, from the primary care audience. And so building up the educational material about the UACR and presentations. And those presentations, I believe, are available online at MCTTD as part of the resources as well. And then in terms of using the dashboard more, being able to, and we'll have an update on that a little bit later on, helpful to know which patients have met versus have not met the quality measure yet. So you can look in the dashboard to identify opportunity lists, to identify patients like that. So hopefully that's something that each of us is already knows how to do, but we can also help with that and do tutorials to get people up to speed on that. And again, using the EHR to help with this. Okay, so now we're gonna break out into two breakout sessions, one with myself and one with Rajiv. So Jackie's gonna split us into rooms, and the goal for these sessions is really to build on what we just talked about, these survey results, and kind of exchange some ideas and talk more about what we can do to help each other in this regard. So Jackie, do you wanna any instructions for splitting us up?
Nope, I've assigned everybody to rooms. Just if you're here from a physician organization, I've assigned you to the same room as the nephrology clinical champion from your practice. You aren't expected to participate, but just so you can be there and listen to the conversation. The only other thing I'd ask is if everyone can turn their cameras on during the breakout rooms, just because, we'll be talking and it'll be interactive. So it would be nice to be able to see everybody's face during that. And then we're going to do the breakout rooms for about 20 minutes. So we'll reconvene like a little bit before 6:45. Dr. Hunt, anything else before I split us up?
No, thanks, Jackie.
Okay, I'm opening the rooms now, and I think everyone should be automatically sorted to them. Perfect. All right, perfect. Mindy and Michael, you can both hang out here like we talked about. Jake and I are going to try to join the breakout rooms. We'll be back in like 20.
other things. So I think it would be pretty easy to add this into our workflow. So yeah.
Great. Thanks, Katie.
Yeah.
Okay, welcome back, everybody. So we thought we would just go ahead now with the next session, which is the report out. So we're just going to go around and ask each practice to spend, just 1 or 2 minutes. Obviously, no slides or anything needed, but just 1 or 2 minutes to. You don't have to answer all of these questions, but just to think about either talking about like what's worked or been really helpful in your practice. So in other words, tips for others, what maybe has been really hard or doesn't work, so that others can learn from that, or we could give advice. And then, and or if you have a specific ask for the coordinating center, anything that we can help with, whether it be education, a handout, a site visit, things like that, that we'd love to hear more about that. So I'm not gonna, I guess I'll pick people. I'm just gonna go by my screen. So I'm not picking on anybody, but David, you're at the top of my screen. So can I ask you to go first?
Yeah, sure, absolutely. So in our practice, we've built the urine albumin to creatinine ratio into our standard labs, and we've done education with each nephrologist. We don't really have an EHR that will give us any flashing or tips or anything like that for anything. We don't have much bells or whistles with our EHR. I think that going forward, we're going to look at the dashboard to see what percentage of our patients are meeting this, and steps we might have to take is we might have to start doing some manual tracking, bringing in either probably one of our medical assistants before the patients are coming into the room to kind of double check and see if they've gotten their all of their labs done, including the urine albumin to creatinine ratio.
Great, great. Thanks very much. Imad?
So nothing specific other than adding just as a change of what I used to do from ordering the protein to creatine to microalbumin to creatine ratio. That's a change, and I think by building it in the preference list has made a big change for me. The only thing that I'll be looking at is if we can have a way to make sure that all these labs that we are sending or lab companies, have they been submitting these claims for the test as it's supposed to? And I'm going to be working with our PMC to make sure that to follow up on that.
Great, right. Yeah, that's something that came up in our breakout room as well, which is the capturing the right testing on the back end can depend on the lab that's used. So I just want everybody to know that that is something the coordinating center is working on. I told the group in my breakout room that we discovered that we weren't doing it properly at Michigan Medicine, actually. So all of our labs, if some of you may use our labs as well, we were not billing it properly. And so that was a big issue for us. And we worked on that, and we are taking that lesson and advocating with other labs as well.
So can you expand a little bit more? What was the problem? So at least go back and talk to them.
So in order to get credit for HEDIS and then for this measure, right, you have to have testing for both the urine albumin and the urine creatinine in order to have the ratio. So you have to have those two. Our lab, it turns out, was only billing for the urine albumin, which didn't actually meet the measure. So we had to communicate with them, and they weren't getting paid for the urine creatinine. So it was just, honestly, it seemed kind of crazy. I think that was a carryover from in the past when only the urine albumin was required, and so it was never changed when the HEDIS measure was updated to require the ratio. So we were able to fix that working with our pathology lab, and that is something that we're trying to make sure that other labs see this, and because again, when we get to look at the data as a whole, we can see where there seem to be some black holes, like that we're not getting any of these results from this place, and it looks like this more of a systematic billing issue. So we are working on that on your guys' behalf on the back end as well. But I'm glad that you guys are also advocating and looking into that. Claudia? Oh, Claudia, I think you're on mute. Oh, I don't know if Claudia is busy. Claudia, are you available? Okay, maybe I'll come back to Claudia. Ilka.
Yes, hi. So at U of M, we get our urine albumin to creatinine ratio and urine protein to creatinine ratio with every patient that comes to the main hospital kidney clinic. And that's how we're capturing, I think, most of our albumin to creatinine ratios. I think some of the issues that we have, which we just talked about in the small groups too, is that not everybody is leaving urine samples. And then we also have satellite locations that do not have this built in, where the urine studies are not automatically done. So for us, it's once somebody checks in, it's actually our MAs that then order it. I believe it's our MAs that order the testing. Some things that I would like to do, and I think from talking to you guys, some places actually have this done where we have automatic urine testing with a referral to nephrology. I feel like that would really ensure that everybody has the right testing for multiple reasons. But that has been difficult to do at U of M, at least, to be able to have the primary care providers or whoever places this to get the test done. So that would be, it would be interesting to hear what other places have done and potentially how they've overcome that problem if they're able to, you know, use the testing and the referral screening.
Thanks, Ilka. Kunal?
So kind of what we were discussing, I think it's been just kind of education with the other providers, making sure they understand the importance, and they all been practicing, so they're pretty senior, so they obviously do. And we also have an MA who kind of looks through the appointments and make sure patients, if they're scheduled for example, for Friday, they just kind of make sure, give them a call, make sure they got all the blood tests that was ordered, and make sure they're up to date on the orders that was put in. So pretty much, I think everything else that pretty much everybody else has been doing, nothing unique to our practice.
Great, thank you, Kunal. Brett?
So we, in our EMR order set, for a routine follow-up, we have UACR as part of our standing orders. So if a patient comes back in 2 months or 6 months, it's pretty easy to check the UACR for when they come back. I'm not sure if some of our issues are as outside labs draw the labs, if it's not just the UACR, but other labs where actually some of the labs are not getting drawn. And so that might be interesting to deeper dive in that, because we as a group have talked about the importance of getting UACR for all CKD patients with risk factors, especially diabetes. And we've made an effort to do UACR instead of UPCR. And so I think as a group, we just have to figure out maybe where we're missing some of these patients and troubleshoot, and so that we can capture all the patients.
Great. Thank you, Brett. Paul?
Yeah. As again mentioned in the breakout room, I guess we're lucky enough to have a relatively small group of physicians, so it's easy for me to encourage the ordering of the test. So for instance, this meeting will give me a good chance to, speak to them yet again. It would be interesting to know why we're not at 100%. That'd be an interesting thing to know. Is it the physician or provider didn't order it? Is it the patient didn't get it? Wasn't aware of these lab problems that you just described. It would be interesting to know, but I guess that probably we don't have that kind of granular data.
No, I'm glad you mentioned that. I think you can look into it. It will take a little bit of work, but we would be happy to partner with you in doing that work. So, for example, one of the things that has been mentioned, and maybe one of the themes from this, is using the dashboard to identify the specific patients. And if you go in there and you think you have it done, but it's not counted in there, then definitely let us know. We want to know case by case and go through and see what the disconnect is, if there is one. We've done a lot of work on the back end. That's why this is a new metric. We wanted to feel comfortable with the data. But if there are things that are missing there, and you might find things like, oh, maybe this is the certain population for whatever reason doesn't get the standing order set or something like that. So that's where that dashboard might be really helpful to identify specific cases. So you should be able to see who's meeting it, who's not, and where the gaps are. Great, thanks, Paul.
Sure.
Vashti?
So again, we're a small group, like 4 only. We share the same workflow with dot phrases. Also, just to pull the last test when it was done, the order set's easy with Epic. So we're all using the same method of ordering and monitoring. Also, the MAs, they remind the patient with the labs when they remind them with the appointment, and they emphasize just to do all labs, including the urine. So all over that's helpful. I'll be happy to elaborate more on the dashboard. I did not access it. I think I had some troubles with it. So that would be great if we know the patients and to see if we still see them or not, why we're missing these patients. There are not many. So that could be contributing to why we don't get the numbers, actually.
Yeah. Okay, great. Yeah, and I know we all are super busy, and the dashboard is another thing to look at. It's relatively user friendly, but if anybody wants to have a one-on-one tutorial with our team, we're happy to go through it with you in real time, like on a Zoom call or something like that. So that is definitely something that I hope all of you take away from this, and we can set it up at your convenience. I don't think it would take more than like half an hour to just kind of go through, and it might be an eye opener, hopefully.
Yeah, perfect. I'll be happy to do that, actually.
Okay. Yeah, we'll make a note of that, and we can follow up with you.
Thank you.
Yes?
Yeah, I don't have too much different to add. I think the same themes going on here. So we've definitely changed our templates to add the albumin creatinine ratio to all our new patients. So every new patient coming into our office gets that automatically. We order them. We don't rely on the primary care to order them. So I think that might be why we're having a little more success with that. The follow-up visits is just physician dependent or APP dependent to order the lab. So we definitely have added that also to our template. So it's easy and available for physicians to order it. We've done a lot of education at our section meetings, so they know the importance of that. So similar themes. We haven't done much with the dashboard, and also after this meeting, I definitely want to delve in and see which patients are not getting it and why, and see if there's some more common themes. We've had some issues with outline labs and things like that. So
Yeah, those seem to be a couple of themes that have come up, and we'd be happy to follow up with you as well to, do a quick thing to go over the dashboard. And I was telling the people in our group how we had a site visit to your practice, and mainly that we brought lunch, but and it was not low carb. We should rethink that next time. But anyways, I hope that was helpful, and that's something, again, we'd be happy to do really at any practice. I mean, with some lead time to schedule and things like that. Or what we did with Jess's practice in Traverse City was we coordinated it around the regional meeting that was in there anyways in the fall, in the spring rather. So those are things that, again, we're happy to do. Hinjo?
Hi, sorry, I have a hyperkalemia in the ER, so I'm going back and forth on the phone with them.
Oh, no worries.
I think, yeah, try to echo what everybody else said. In our small group, we were talking about adding the UACR to order sets. A lot of the order sets already had the urine protein creatinine ratio, but not the UACR. So we all kind of talked about adding that in, and so we're adding that on our order sets for the different stages of CKD. And then we're working on opening our own lab right across for the hall from our office to try and help streamline things and make it easier. So adding that as a part of our order sets as well will definitely help make things easier. And then I think Rajiv talked about the nomenclature and how people are reporting them as the microalbumin creatinine ratio. I think that's a really good point too. A lot of the times I feel like that gets lost in translation a little bit just on that little easy, simple change in the name. So I thought that was a good point too.
Yeah, and as you heard, we had our own little struggle at Michigan, and again, we were actually, it wasn't a clinical issue, it was a billing issue. And so if we're finding that, we're looking for that for you guys. Somebody, Rebecca from the PO mentioned the ordering issues in our small group. So these are all systematic things that we're happy to work with you on as well. So, hey, Claudia, it looked like you were busy with a patient. Do you have time now to chime in?
Yeah. So same thing. Lots of calls from the ER right now. So I don't actually have a system, so this is very, very useful. What I'm gonna do, we have a system where every patient that leaves the clinic, we have a set of orders. I'm just gonna add this one and put more emphasis on ordering. My office staff really helps me out with this.
Great. So we're gonna shift now to the next section, but just before we do that, I just want to summarize. I mean, I really appreciate everybody's engagement and feedback on this. It was cool to hear that a lot of centers, a lot of practices, I guess, have already incorporated this testing into their order sets, which is a really nice systematic approach to this. One of the themes, I think, is that a lot of us, it sounds like, aren't routinely using the dashboard. And so the couple of people that mentioned they'd like follow-up, we will do that. If you want to mention in the chat to Jackie, Jake, or myself that you're interested in that, we can follow up with each group individually just to give you a quick tutorial, walk you through your data to show it. It's just muscle memory to know how to do that and to look at that. But that can be helpful for identifying, potential holes in the data or anything like that. So great. Thank you for everybody's feedback. I'm going to go ahead and share my screen again. Okay. Can everybody see this the practice again, or the presentation again?
Yep, we can.
Great. Okay. So next, we're just going to go over some of the data that we have from each of the practices and the collaborative as a whole, just so you have an idea of what the patients look like, and both on the whole compared to the PCP and compared to each other's practices. So first of all, some A1C data. Honestly, not that different between nephrology and the PCP practices, and pretty decent actual mean A1Cs. And this is the A1C by practice, and you can see that, you can see that there's not actually that much spread. It ranges from about 6.5 to 7.1 in terms of the range. So doesn't look like there's a huge outliers in terms of diabetes control. Similarly with body mass index in the obese range, not too far different between the primary care practices and our practices. And again, when you look across our different practices, not a huge spread really. And then in terms of eGFR, Not surprisingly, our practices tend to see patients with more advanced chronic kidney disease compared to the primary care practices. So that's kind of obvious. And in terms of the breakdown by stage, you can see that, again, not surprisingly, this is just presenting in a different way. We follow a lot more of our patients in the latter stages of CKD compared to the primary care population. And again, just to see what each other's practices are doing and where you fit in here, you can look at where your practice is. And again, not a huge spread in terms of the mean or median GFRs. Maybe a little bit of an outlier here in terms of slightly higher, but again, a smaller number. And then in terms of albuminuria, once again, like the GFR, not surprisingly, we see more albuminuria in our patients with kidney disease. And then the breakdown, again, more patients. Honestly, this kind of surprised me. Like we have a higher percentage than the PCPs, but I feel like 50% of my patients are in the A3 range sometimes. So 8% seems awfully low, but I think, obviously this includes a lot of other patients. And then this is, again, comparing it across the collaborative by practice. We see a little bit more of a spread here, but not huge, not the difference between like a huge nephrotic range kind of thing and other things. So there's some variability. And then getting into actual therapy. So obviously one of the key things that we've been talking about throughout the collaborative, the time that since we started, has been prescribing the novel agents that have been shown to be beneficial, the SGLT2s and or the GLP-1s. So this shows the percentage of nephrology patients on an SGLT2, pretty good, 41%. And significantly higher than for the PCPs. And this is, of course, patients with type 2 diabetes. The GLPs are a little bit low. I think we're probably catching up on that, especially since the FLOW trial was prescribed and we're seeing that there are kidney-specific benefits to this. But if you look at one or the other, over half of our patients, which is pretty good. And in terms of combination therapy, a smaller percentage, but at least one or the other over half of the patients, which is just quite good. And by EGFR stage, this just breaks it down by that. Again, with nephrology, not surprisingly, we see more patients in this range. Honestly, not that huge difference from the primary care, but I think it's really good that in the stage 3, which is hopefully early enough to make a big difference for our patients, we're seem to be a little bit ahead of where the PCPs are. And same with the use of the incretin mimetics, which is the GLPs and the GLP/GIP ones. So slightly ahead in terms of the more advanced kidney disease until you get to stage 5. And then breaking it out by albuminuria stage, the pretty even spread across. Maybe this is an area for improvement for us in terms of boosting up the use of these medicines, because this is probably the highest risk group and the group that would benefit the most from these medicines. But again, ahead of where the PCPs tend to be in general. And then this is the comparison slide. So if you're competitive, well, we're all competitive, right? As physicians to some degree, right? So you can look at where your practice is, and we've just split this up by tertiles. So the lowest tertile is in the red, the second tertile is in the yellow, and the highest tertile, the highest percentage prescribing is in the green. So just kind of red, yellow, green. And you can see the spread of SGLT2s, incretin mimetics, either or both. And again, this is not obviously to judge anybody. I'm kind of teasing about the competition, but it does show you where you're at compared to some of the practices. And hopefully, if you're in the green, it's something you want to keep working on and build up. And if you're in the red, definitely some opportunities for improvement. And hopefully, all of us are picking up some tips from tonight's feedback in terms of what can help each other. And again, I'm not going over specific individual data, and I know I'm going kind of fast with these, especially with the practice ones, but we will once again share the slides afterwards so that you can take a closer look at your convenience. Okay, and then this is just a breakdown of what our patients look like by the NKF's heat map, or the KDIGO heat map, by GFR categories and abdomen area categories. So this is the primary care practices and what patients are attributed to them. Not surprisingly, they have a lot of patients in the normal or low risk range. Whereas for nephrology, obviously, we have a much larger spread in this middle region and fewer patients in this area. But I liked to look at this. I found it helpful just to get a sense of the numbers in each of these different areas. Okay, I'm going to turn it over now to, I don't know if Jake is presenting or Jackie, to talk a little bit about the dashboard.
Absolutely. Yeah, so we'll just have a couple slides to go over just a little bit about how attribution works within the dashboard and the requirements around the dashboard for this year's VBR cycle. If you wouldn't mind going to the next slide, Dr. Hung. So first, before we get into the attribution, just wanted to talk about access to the dashboards. So the way that you can get to the dashboards in general is by going to mct2d.org, and then you'll see in the upper right-hand corner, like it's circled on this slide, there's an area that says the patient data dashboard. That's where you log in. Though prior to doing that, you need to make sure that you have access to the dashboard. The way that that works is your physician organization will submit a form to the Michigan Data Collaborative, who hosts our dashboard. The form is on our admin portal under PO resources. After that, you get instructions from MDC on how to access it. And from there, you'll be able to log into the dashboards. Some of you may already have access. If you aren't sure, you can check with us and we can let you know. But this will be relevant as we talk about the VBR requirement in a couple slides. Next, please. And as far as the nephrology model, so we've had nephrology attribution in the dashboard for a couple years now, but we do want to review this since this is our first cycle with a performance measure, so it's especially relevant. The nephrology model that we use is one that Blue Cross Blue Shield has developed for their specialist value-based reimbursement. We thought it would make sense to align with them since they had a model developed already, and the majority of patients in our dashboard are Blue Cross Blue Shield patients. So this uses an algorithm that we'll review on the next slide that does like retrospective assignment to a nephrologist based on like their relationship and how often they're seen to try to link a patient to the physician who is considered kind of most responsible for the patient's care. And through this, each patient is only assigned to one nephrologist. So, you know, within the collaborative, a patient may be assigned to multiple specialists or different specialists, a PCP and a nephrologist, but there will always only be one nephrologist that a patient is assigned to. Next slide. And this is the attribution model. So first it's looking at when the patient has had like their most recent evaluation and management visit. It looks at first 12 months if they've had a visit. If none in 12 months, it looks if there was one in 18. And then if not, if there was one in 24 months. If a patient hasn't been seen in 2 years, they're not going to be assigned to a practitioner. And then once a patient has been identified to have had a visit, it goes to this next kind of blue box that has the assignment rules. So if they've only seen one nephrologist in that time span, they're assigned to that nephrologist. If they've seen multiple, the next thing it looks at is who has the most visits. So if someone saw Dr. Hung 3 times and Dr. Saran twice, they're going to be assigned to Dr. Hung. Let's say that's not the case though, and the patient has seen each physician twice, Then they're going to look at the most recent visit. And so whoever has had the most recent visit with that patient is who they've been assigned to. And if that most recent visit, again, isn't in the last 24 months, they're not going to be assigned to anybody. So we have a document that we've created that details this model, has these images, and also kind of the full explanation for it. Gives a little bit more background on like our patient data dashboard, as well as like the current measure that we're having nephrologists work on with it. We'll send that document out when we send out the slides for this meeting as a follow-up, so you can have that to reference as well. And then next slide. I won't go over this one. I just had this more on here as an appendix. It's kind of what I just talked through as far as how the attribution is assigned with the different months and the rules for it. Just wanted to have this text available to you all when you get the slides so that you can kind of walk through that model like we just did. And then finally, the requirement that we have related to the dashboards for this value-based reimbursement cycle is to sign in to the dashboard once by December 1st. So the rationale behind this is, as we've talked about, we are launching our first performance measure. We really want to ensure that the clinical champions are familiar with the data and the attribution, that you know where to find things, because like we talked about in the breakout rooms and in the report outs earlier, you can really drill down to that patient level and see who hasn't gotten a UACR screening. We'll send out reporting as well, but the dashboard is going to have like more frequent updates and in some cases more current data than the reporting that we're sending based on when you're signing into that. So it's a helpful tool that we want to give you some more familiarity with. And like we said, if you don't know if you have access to the dashboard, or like we talked about before, if you want a tutorial or to be walked through how to use it, we want to be able to support you with this requirement. So please reach out to us with any questions about either access or dashboard use, and we will make sure that we make this as straightforward as possible for you. Great.
I just want to add, you know, we decided to do this because first of all, we think the dashboard is really great. We put a lot of work into trying to make it a useful tool, and many of you commented about how it'd be great to be able to track this, so that this is the way to do it. But we made this a VBR requirement because if any of you are like me and you need a deadline to do something, right? You know, like this is your deadline. Like this is kind of forcing you to log on to the dashboard. I hope I really expect that, I really hope that it will be worth your while. And, you know, Jessica and Wajdi, we will reach back out to you to set up a time to work with you guys and walk you through this. Anybody else that wants to do that, we're happy to do it as well. But I'm hoping it's a 2-for-1. It's going to check off one of your VBR requirements, and it will hopefully be a real practical aid to meeting these requirements going forward. Thank you, Jackie. So I'm going to turn it over now to Rajiv, who's obviously the Associate Director for the MC2TD nephrology component. And, you know, we always try to provide some educational updates at these meetings, and we've talked about a variety of different things in the past. And this time we did a poll, and just about everybody picked CKM. We left it wide open, or you could pick other topics. And I guess nobody wanted to hear about Medicare, Medicaid updates, which is probably good because the government shut down, and it's who knows, it's you know, wouldn't have been a very fun topic. But this is, I think you've heard a lot about this hopefully already, and but I'm really looking forward to Rajiv giving us a little bit of a deeper dive. So Rajiv?
Sure.
So Mike,
Yeah.
Claudia?
yeah, I'm so sorry to interrupt.
No,
I just want to ask a question because I know we got a message, an email saying that one of the requirements was to log in to the dashboard. And I thought I did. Is there the possibility that we can get a feedback that has been done?
We can absolutely go through and pull anyone who has done this and reach out to anyone who has and let them know that it's complete, and anyone who hasn't and let them know that theirs still hasn't been completed. So yep, we can definitely do that.
Yeah, it wasn't a straightforward process. I had to get an account and an email, and I think I logged into like 3 different places, then I realized that wasn't it. So I just wanted to know, make sure that I did actually do it.
Yeah, absolutely. We will look into it and let you know. Mhm.
Thank you.
Yep. Thanks for bringing that up, Claudia.
Yeah.
Hey, Rajiv.
Are you going to manage my slides then, Mike? Or?
Sure.
Okay, so thank you for inviting me to give this overview of the cardiovascular kidney metabolic syndrome. Most of you should have heard about this by now. I certainly have been hearing about this for the last almost couple of years. I think it came to my attention out of the blue, basically after an invitation to a KDIGO meeting where they were going to talk about screening for kidney disease and strategies towards earlier screening and prevention of kidney disease. So this was a topic that was brought up just before that meeting, and that's how I got introduced to it. Next slide. So it really relates to not just kidney disease, but as a background, I think it relates to multiple chronic conditions that are highly prevalent in the US. And this slide is from work done by the CDC researchers, published in their very high impact journal, Preventing Chronic Disease. The data come from the behavior risk factor surveillance system. And it shows on 2 panels, one on the left, one on the right. As you can see, this y-axis is the prevalence, and then at the bottom there are trends, and they've covered a 10-year period from 2013 to 2023, showing that in the US, if you look at all adults, over 70%, almost 75%, or close to 80% in 2023 have at least one chronic condition. If you look at different age categories, the oldest, of course, over 90%, well over 90%, I would say almost 100% of people that are over the age of 65. This green dot is 65-year-old. The blue one is 35 to 65, 64-year-old, and then the green is for younger people. So they've divided each assessment, each analysis into 3 strata. The orange line is just all. It depicts the average of the entire population. Was there a question? So all it shows is that in the very high older age group, of course, almost everybody, close to 75% in 2020. If you just look at 2023, close to quarter of the patients or people in the middle age group have at least one chronic condition. But even among the younger people between 18 to 34, over half, in fact, 60% have at least one chronic condition in 2023. And it's been rising among the young. So this is a pertinent finding that for the other age groups, there's not much change. And overall, there's some change, but most of that is attributable to the youngest age group, 18 to 34 years. So things are starting earlier. And if you look at 2 or more chronic conditions on the right here, the story is much the same. Stability above 75% of folks above the age of 65 have at least 2 chronic conditions. More than or close to or just above half of individuals in the age group 35 to 60, middle age group, I guess, the intermediate age group, I should say, have at least 2 or more chronic conditions. But quarter or more than a quarter, nearly 30% of younger individuals now have, in 2023, the latest data that's available in the behavior risk factor surveillance, have at least 2 chronic conditions or more. The next slide, Mike, then shows the split between various chronic conditions. Again, this is the behavior risk factor surveillance system. It's mostly a phone survey, and it's sort of it's self-reported information, so there are some limitations, but it does point to important trends. And in the youngest age group, the most notable finding here is the top 2 conditions. These are 12 conditions that they looked at in this survey, and the top 2 are obesity and I believe depression for the youngest. For the intermediate age group, 35 to 64, the top conditions include hypertension, obesity, and high cholesterol. The green is obesity. Diabetes. I think the dark green was obesity, I thought. It's dark green, yes.
Yep, the dark green is the obesity. Yep.
That's obesity, yep. And in the oldest age group, older age group, above 65, obesity is much lower. It's mostly arthritis, high blood pressure, and I think high cholesterol were the top three conditions, not much change over time. So a lot of comorbidity burden in the US population. Next slide. And then so it behooves us to understand why that may be. And is it possible that many of these comorbidities are linked to the so-called cardiovascular kidney metabolic syndrome, which is kind of a new angle or a new definition for a disorder that most of us have been aware of for a long time. And metabolics, it was variously known as syndrome X, metabolic syndrome. But I think over the last 2 or more decades, it's become clear that all these systems are interconnected. Surprise, surprise. But especially for the first time, I think kidney disease has found a place in the center of this syndrome as a very important, both as an important organ and one that sees so much blood flow. Again, the physiology I'm not going to get into, but the kidney sees over 25% of the cardiac output every minute, 20 to 25% of the cardiac output. So it sees a lot of blood flow. It has a lot of blood vessels. And it's not surprising, therefore, and it regulates the cardiovascular system in many ways and is a major organ system controlling blood pressure. So the bidirectional link that we've been aware of between kidney and heart, the so-called cardiorenal syndrome, has now found its prominent place or rightful place, I think, at the seat at the table, if you like, as it concerns the community, as an equal partner in the cardiovascular, kidney, and metabolic health profile. Shouldn't forget the other most important organ, which is the liver, the brain. So in fact, all organ systems, but somehow the terminology has restricted itself to CK and M. It's a health disorder. It's been defined very simply as a health disorder due to connections among heart disease, kidney disease, diabetes, and obesity, leading to poor health outcomes. This is a simplified definition. And on the next slide, you have the AHA detailed definition. And you'll be getting the slides and you can read the text, but it's a systemic disorder. So if somebody has diabetes, they have the cardiovascular kidney metabolic syndrome. It's not just diabetes. If somebody has chronic kidney disease, they have this syndrome, etc. So it's a systemic disorder and characterized by these complex pathophysiologic interactions among metabolic factors and these specific organ system dysfunction and disease. But the overall context is a high rate of adverse cardiovascular outcomes, which tends to be the final common pathway in many of these conditions, although individual specialties are concerned about, for example, us nephrologists are concerned about progression to ESKD, but most of our patients literally die of cardiovascular disease much before they can ever reach end-stage kidney disease. And the other big aspect or big picture point is that it includes people at risk for cardiovascular disease as well as those with the condition itself. So it lumps them all together in one big milieu, as it were. And clearly, many of these conditions are based at the foundational level in lifestyle, self-care, that are in part the individual's concern, but largely result from social determinants of health and political determinants of health and economic determinants of health. Next slide. And this pictogram has been shown in most of the talks and presentations. It comes from the American Heart Advisory, published in, I think, summer of 2023. And depicts very nicely stage 0, which is not really a condition. It's just normal health, and it shouldn't be considered a stage of the disease per se. moving on to stage 1, stage 2, stage 3, and 4. So there are really 4 stages, not 5, just to be clear. Stage 1 is, and it's centered around visceral obesity. So the entire syndrome is actually, except for very pure types of, say, kidney disease or pure types of liver disease, etc., it's mostly centering around the fact that there's visceral obesity at the core of it, if you like. And visceral obesity can occur at different body mass indices. And that's the beginning of it. And there's no metabolic abnormality, although some would argue that obesity itself can predispose to cardiovascular disease and be associated with cardiovascular outcomes without any obvious metabolic derangements. For visceral fat is associated with inflammation, cytokine production, and end organ damage. But stage 2 is really where all the metabolic risk factors combine to form this, and various metabolic factors are included here: hypertriglyceridemia, hyperglycemia, type 2 diabetes, moderate to high risk CKD. Even the non-metabolic etiologies of CKD have been thrown in here in stage 2, because once somebody has kidney disease and a CKD milieu, that can contribute to cardiovascular risk because of the bidirectional link and the abnormalities that accrue as a result of having kidney disease. Hypertension is here, metabolic syndrome, visceral obesity is included here, which is the hypertriglyceridemia, which is part of metabolic syndrome. So there's a big soup of metabolic abnormalities and hypertension. Stage 3 is once somebody develops subclinical disease, mostly detectable here in the form of these pictures showing subclinical heart failure or subclinical atherosclerotic cardiovascular disease, coronary calcification shown here. But there can be other types of subclinical abnormality. Risk equivalents of subclinical cardiovascular disease in stage 3 are if someone has very high risk CKD, i.e. stage 4 or stage 5 CKD by the KDIGO heat map, they straight away find themselves here. Or if someone has a very high predicted risk for cardiovascular disease using risk calculators, then they can also be placed here in the absence of non-invasive testing, which very often may not be available or may not have been performed. But I think echoes and coronary CT, coronary calcification by CT scan are becoming more and more frequently used as non-invasive tests for cardiovascular disease. And the last stage is, of course, clinical cardiovascular disease, where it becomes symptomatic, and the different types of cardiovascular disease are depicted here. End-stage kidney disease would be stage 4 disease here. And it's, I think stage 4 CKM has been divided into A and B with and without kidney failure. So that's another nuance that you may come across. But that's the cardiokidney metabolic syndrome and its stages. Next slide. Yeah, we did some work looking at the National Health and Nutrition Examination Survey data, and we were surprised and yet actually shocked to see that most of the US population, this is looking at data from 2001 in 4 yearly cycles till 2020, different stages of CKM syndrome, the blue being stage 1, the yellow or the dark yellow or orange stage 2, and then blue is stage 3 and stage 4. I felt maybe stage 3 is underrepresented here because they didn't have non-invasive measures of cardiovascular disease in NHANES, and they used the PREVENT equation, the risk prediction equation, to classify people here in this stage. The vast majority were in stage 1 and stage 2. I guess this represents a huge opportunity for prevention. So if you have people in this earlier stages, which many of us may not see in our practice, it's in primary care, in the realm of primary care, but it's a population health problem more than a clinical problem, I think. And so almost close to 90% in 2020, and we don't have the most recent NHANES cycle yet completed. I suspect it's a little bit higher. close to almost 90% of the general US adult population, the slide is telling us that is suffering from this cardiac kidney metabolic syndrome. So some have argued, is it normal? Is it something normal that people have since it's so highly prevalent? And I think that may not be the right approach to thinking about it. So, but this is what it is. This is the prevalence. Again, in health system setting, it'll be even higher. So the general pop, and they'll be higher later stages, I suspect. Next slide, Mike. This slide is again from the same article, the American Heart Kidney Advisory, and shows the central role that excess or dysfunctional adipose tissue plays in all of this with the production of adipocytokines. Some of it goes straight and deposit in the liver. So the liver disease, the metabolic abnormality associated fatty liver disease. It's called, I think they've changed the acronym to MASLD now, ectopic. It's a form of ectopic fat deposition outside of fat depots, leading to and potentiating systemic inflammation. The orange accentuated phenomena, inflammation, oxidative stress, insulin resistance, and vascular dysfunction really is the syndrome or the underlying pathobiology. And the other things, just having visceral obesity can lead to hypertension, dyslipidemia, metabolic syndrome, and diabetes through the cytokine mechanism, and then affect end organs such as the heart and the vasculature. On the other hand, adiposity also predisposes to kidney disease directly, both through hemodynamic effects and or inflammatory and structural effects, including fat that's sitting around the kidneys, which we don't often measure the quantum of. And then this slide shows you the bidirectional linkage between heart and kidney problems. Albuminuria, of course, as a manifestation, bone mineral disease leading to vascular calcification, and again, effects on the cardiovascular system, neurohormonal activation, plasma volume expansion that occurs in kidney disease, and also just in the setting of obesity can lead to this cycle of events, complex cycle of events, varying, highly heterogeneous, depends on individual and their risk factors and their lifestyle and many other factors that determine the progression. But this is the general schema, if you like, for explaining various, again, a lot needs to be understood. There's a whole body of literature in the back end of this slide. Next slide, please. So the scientific understanding of the CKM syndrome is highlighted here. And the points that the American Heart has been making is that the syndrome is it's got many parts, but the overall effect on morbidity and mortality is not just a sum, but beyond the sum of its parts. It's sort of multiplicative. These things are interactive, as I've sort of alluded to in the previous slides. These metabolic risk factors are directly responsible as causal towards end organ damage, affecting the cardiovascular system. That includes the heart, of course, and the kidneys, which are a very prominent part of the cardiovasculature system because of the high blood flow requirement for kidney function. And the mechanisms really are hemodynamic, followed by metabolic, or can be independently metabolic, inflammatory, and eventually fibrotic. This is a very, very oversimplified version, but important to the understanding of the syndrome. Next slide. And the kidney, why it's been placed at the center, I don't think it was just advocacy on part of the nephrologists who were represented in this American Heart Advisory, but following the grasp of a body of literature that suggests that low GFR and albuminuria independently increase the risk of major cardiovascular events and cardiovascular death. And the kidneys, especially in the presence of diabetes, is particularly associated with very high risk of peripheral arterial disease. And we've done some work showing in the DOPS study, for example, where very high prevalence of PAD among dialysis patients, certainly, but there are other studies showing similar findings for CKD patients as well. So this is a problem. Vascular calcification, of course, predisposes to that and increases both the PAD risk as well as cardiovascular risk. The pro-inflammatory state that kidney disease represents also potentiates the cardiovascular risk, and as well as the development of heart failure and progressive CKD. The bidirectional, the new neurohormonal activation, fluid retention, and inflammation that go hand in hand. And then finally, anemia is common in CKD and exacerbates the impact of cardiovascular disease by reducing the oxygen availability in the circulatory system. Next slide. So multiple mechanisms whereby the kidneys are very central to making things worse if they suffer along with the cardiovascular system. So there are some key gaps. This is a broad understanding, but there are key gaps in screening approaches for CKM syndrome. And I think this is where the KDIGO group was struggling, that if you go by the paradigm of the CKM syndrome, it would argue really for early screening, early life screening, as well as earlier screening for kidney disease, knowing full well that there are no clear guidelines at the moment in the kidney world. Certainly the US Preventive Task Force and others do not advocate early screening, although I think there's going to be a shift based on other studies that are coming out and the notion of the CKM syndrome. So perhaps this will improve earlier and earlier screening and induce preventive efforts at not just individual but community level. But there are key gaps in the knowledge about the lifespan, screening across the lifespan. When should you screen? How should you screen? How frequently you should screen? When and how to screen for metabolic risk factors and CKD in adults, of course, as I mentioned. The role for detecting subclinical cardiovascular disease and screening for social determinants of health is another huge and important topic where there are still research is ongoing and more is coming forth, more knowledge is coming forth in that area. Next slide. And other areas where which are recommended as strategies, but there are huge gaps as well, is this notion of interdisciplinary care approaches. I think we've moved to an extreme of primary care, specialty care. Specialty care takes from primary care. There's back and forth, but there are silos, and I think one of the big lessons that is being promoted that our siloed approach is actually not helping. And perhaps there should be more communication between the generalists and the specialists and between specialists. So the so-called sort of integration or multidisciplinary care for these complicated patient paradigms or disease paradigms. So early life prevention is getting emphasis again, but there are gaps. Strategies to support weight loss, of course, are huge. And that's since CKM syndrome is centered around visceral obesity, this is a hugely important, but how to do it at not just the individual level, but how to maintain, support weight loss through the lifespan. Use of cardioprotective and anti-hyperglycemic drugs with diabetes and those at risk for CVD. I think there's more and more practice experience being gained in this area, as is for use of cardioprotective drugs, other cardioprotective drugs as well. Use of non-statin lipid-lowering agents is a new area. I guess this requires further work. And management of cardiovascular disease in patients with established CKD, of course, is another. The therapeutic nihilism that used to exist, I think, is much less now, but may be an issue still, and participation in clinical trials for people with kidney disease. So some of the gaps in evidence emphasized by the American Heart Advisory. Next slide. The next few slides are actually details of management of each stage of CKM syndrome. And I'm not sure if we have time to go through every bullet point on this slide. But stage 0, mainly to maintain cardiovascular health. And it's about prevention, essentially, and avoiding weight gain. Stage 1 is the visceral obesity management and requires some special knowledge about helping people lose weight in a non-judgmental way, and the knowledge that comprehensive lifestyle intervention is the most effective, and also the awareness that the more percent body weight loss without compromising nutrition is associated with better outcomes. So that's important, up to and including incretin analogs, the GLP-1s and others, and bariatric surgery if nothing else is working. But increasing, I think the bariatric surgery will go down with increasing uptake of GLP-1s, unless we still don't have long-term data. And if there's failure or side effects, then bariatric surgery, of course, is still available for extreme cases of obesity. Next slide. Stage 2, a whole host of metabolic abnormalities listed there with some nuanced individual medications and approaches to care. And then finally, stage 3 is subclinical, which is not that different from stage 2, but just more emphasis on medications and follow-up and heart failure management, SGLT2s and other medications. Next slide. And stage 4, of course, is the most complicated patient with a whole host of issues of multi-comorbidity. Next slide. I don't think I'm going to go through every bullet. That'll just take all evening. In the big picture, I think these kidney and cardiovascular protecting agents, the simultaneously kidney and cardioprotective agents, are the new ones in town, and there's a whole host of them, which is great. And they are being called the so-called pillars of treatment, the SGLT2 inhibitors, the GLP-1. More and more experience is being gained. I must say the GLP-1s are still new, relatively new, and while they're showing high promise, the long-term effects are still somewhat unclear. And then the non-steroidal mineralocorticoid MRA antagonists with the foundational treatments, including RAS inhibitors, ACEs and ARBs, and statins, which have had long years of experience and use. So these are the 4 or 5 pillars, and there may be more coming in the making. But I just wanted to emphasize the bottom, not pillar, but the foundation, because pillars can be weak, and pillars will be weak without a solid foundation. So this underlying lifestyle changes are so important. And I think as nephrologists, we see patients towards the end of the spectrum, and we don't have time often in clinic. But if we could develop systems in our practices that would support and address these issues in our individual counseling sessions with the patients, or invoke other support staff that can do that or have more time to do it, I think that's hugely important, because these drugs don't work as well in the absence of a lifestyle intervention. So resistance to these drugs or their effects may be seen. And I think my last slide or last 2 slides are the next. So this is my second to last slide. Again, there are gaps in the scientific understanding in the socio-ecologic framework. It's not only about individual predisposition and multiple factors, including genetics and many other stresses, and microbiome is another huge topic, hormones, early life events. But there's so much in the background about individual behavior, addictions, the brain, the CNS, gut axis, and so on, relationships and the community, and the societal factors, which may be well beyond scope of an individual clinician practice. But the awareness that these factors are playing a role, I think, is important, even in clinical practice. And I'll end with the slide that many of you may have seen. It's actually a small segment in the classification, but this Life's Essential 8 was a CK AHA advisory that came out just a year before the CKM syndrome advisory, and was an improvement over the Life's Essential 7s, which came out in 2010, the guideline. And this is an amazing review of lifestyle modification and all the facets. And so they've divided it into 8 pieces. The top 4 here are actual lifestyle stuff, which includes smoking cessation, alcohol avoidance, or complete cessation. The importance of sleep has been emphasized much more in this particular guideline. Sleep disorders are extremely common, and especially people with more and more advanced kidney disease, and should be considered in the management, and at least there's observational data to suggest that management of sleep disorders can improve outcomes in patients with CKD. Dietary, easier said than done, but dietary advice is crucial. Physical activity. So those are the lifestyle things. And then the 4 down below here are actual objective measurements that we use. So blood pressure, lipid management, weight management, and glycemic management are the 4. So these are the key facets emphasized in the AHA's 22 advisory. And I think they preceded the CKM syndrome. And it makes for very interesting reading. But I think the attention to SDOH in clinical practice, team-based care, and multidisciplinary care are extremely important. Although more data is needed to say what are the best models of care and so on. And I'm sure there'll be a whole host of literature. The guidelines from the AHA are coming for CKM syndrome. This is only an advisory. This document is only an advisory that I've spoken from. They're still working on the guidelines. I think by 2026, there should be guidelines available. A lot of people are working on those right now. And then simultaneously, people are working on quality metrics for CKM syndrome. So more to follow, but I'll end there in the interest of time also and take any questions.
Great. Thanks so much, Rajiv. I really appreciate this overview. Yeah, let me this is our last slide, actually, I think. So
Yeah.
let me just open it up to any reactions or questions or comments about this this area or anything we've talked about this evening.
Yeah. I'll just say that albumin is one of the metabolic factors. Albuminuria, sorry, detection of albuminuria as a cardiovascular risk factor has been emphasized. So that's sort of blends into the CKM syndrome. If somebody has albuminuria, they have CKM syndrome, essentially, unless they have some GM that's only localized to the kidney.
I think it's interesting. I believe it's the American Journal of Kidney Disease has a whole section on lifestyle medicine now. And they even put out a very nice review of the power of plant-based eating, which seems to be a little bit at odds with our collaborative.
Yes.
Somebody's made that point before.
Yeah,
and I must admit, I have not read the new guidelines on diet, the national guidelines that have just come out. I should go back to them. But they also emphasize the importance of plant-based. They're not saying don't stop eating meat, but increase the amount of plant-based food products that you consume.
Certainly, the specialty of lifestyle medicine is willing to say that.
Yes.
Well, I know you've had a long-standing interest in it. I forget, are you boarded in lifestyle medicine?
I don't know that I'm allowed to say I boarded because I think I might have let it lapse. But at one time, I certainly was.
Okay. Okay.
Wow.
I mean, this is right in your wheelhouse then, right? Like this kind of thing.
Well, certainly, I couldn't agree more about the foundation being, centered about lifestyle medicine. And, again, lifestyle medicine talks about the pillars of health, and they would include things like mindfulness and social connection, but certainly sleep, critically important. And that AJKD series is very nice. They talk about the gut microbiome, which is exploding in interest. And so, yeah.
I think it's a C. Jason series, if I'm not mistaken.
C. Jason. Yeah, Mike, you should know better. Yeah.
Okay. Sorry.
Yeah. No. It's but yeah, no, it's a really important area. I mean, when I first heard about this CKM, I was kind of like, well, yeah, like this is what we deal with. But I do think it is helpful to think of it more in that systematic approach. And I've started to change, my emphasis a little bit. I'm curious if others have as well. Just because I do see a lot of patients getting referred to me earlier, right? It's not like I'm not seeing the stage 4s for the first time. Usually, I mean, occasionally, but I'm seeing a lot of stage 3As now, and I'm talking a lot more about these kinds of things, and still some of the medicines and everything, but we have more time to intervene on lifestyle things, I feel like, with those patients. And
The other thing I struggle with is how many medicines do you add?
yeah,
And when, and you know, I saw some practices in the red for GLP-1 receptor agonists, but gee whiz, how many do you add?
and I think that's a fair point. Absolutely. We actually had a journal club recently at Michigan talking about one of the papers that came out describing like the sequential add-on approach versus a like all at once kind of approach. And they kind of concluded that you could add a lot of these things on at once, and that was probably a more favored approach. Kind of like, you know, now we often use dual meds for stage 2 hypertension instead of, you know, just one at a time, for example. And honestly, there was a lot of doubt. We had a lot of discussion about that because I don't feel comfortable adding an ACE and an SGLT2 at the same time, much less along with a GLP-1 or an MRA, you know, all at once, you know. But it does behoove us. There's a little bit of therapeutic inertia that can occur as well, that we have to find the right balance. But I think that again, one thing that I've tried to do more is talk more about the lifestyle stuff. I don't have your background with the lifestyle experience, so mainly I refer them to my dietitian, who's awesome.
Yeah, you got to be careful.
Yeah.
Right. So some of the dietitians are still in the dark ages.
Yeah.
But yeah, if you have a good, you know, because dietitians can also get bored in lifestyle medicine, and they can be a huge resource. And there's a lot online. I'll send people to look at Forks Over Knives. You know, they have a website with, you know, just tons of recipes, and you know, just articles and descriptions of what it is. But
Cool. Others have any questions or comments?
I don't have questions. I don't have comments, and I really have to go.
Okay. Thank you so much for being here, Claudia.
Thank you. Thank you for everything. All right.
Yeah.
Bye.
Anybody else want to weigh in or any questions?
There's going to be a full session on this at the ASN as well. Just I'm not one of the speakers, but it's going to be a very interesting session. And the ISN is holding a symposium this month on the same topic. So I'll be learning some more over there.
I'm glad you mentioned that, Rajiv. Thanks for reminding me. Is anybody going to ASN or any of your partners? I was just going to mention, because if any of you are, you're certainly welcome. We usually have a Michigan reception on the Friday night there. We will again this year. And so if any of you are going or your partners are going, and we would love to invite you to drop by, hang out, and chat and catch up or meet some people from Michigan. Okay, well, I think we have just a minute left, but I guess I'll just wrap up by saying I want to thank Rajiv again for giving this presentation. This is really, you know, it resonated with me because I think it's exactly what we do all the time, but starting to think of it instead of kind of like just purely from a kidney perspective, but in this context of the greater overall health and the overall CKM paradigm, I think is really important. I think one of the other takeaways from today is that a lot of people, it seemed like, felt like the dashboard could be really helpful, both to improve, but also to figure out like what's going on. Because in my breakout room, at least, we heard a lot of people that were surprised their numbers weren't a little bit higher, especially with the systematic ways we have to make sure everybody's getting urine albumin. So as we talked about, we're happy to work with each group to get logged in to check out the data and to troubleshoot. So if you see something that doesn't make sense to you or anything like that, please let us know, and we will absolutely follow up case by case. And then just lastly, another plug, if any of you are interested in, just meeting, either Zoom or a site visit, we'd love to support. Anytime you guys have ideas about ways we could help you, please let us know. Thank you for everybody's engagement tonight. I learned a lot from the breakout rooms and from the reporting out. So I think we have some good ideas to bring back to our institution, and hopefully you all feel the same way as well. But great to see everybody.
Thank you. Bye-bye.